Good evening, this is Don. I'm enrolled at ECPI Master's Program, and I chose to do a theory test on, a theory presentation PowerPoint on Ida Orlando's nursing process discipline theory. So let me start this podcast and we will go through the PowerPoint that I have selected. Okay, it's Ida Orlando's nursing process discipline theory. And Ida Jean Orlando Peltier, she's an internationally known psychiatric health nurse, theorist, and researcher. She graduated with her BSN in 1951. She received her Master's of Arts in Mental Health Consultation. Her background history components are relational statements, inductive or deductive developments, and impact on nursing research and practice. Her main theory, the dynamic nurse-patient relationship, interaction between a nurse and a patient at a specific time and place. The nurse then decides on an appropriate action based on nursing plan of care to resolve the need in cooperation with the patient. If there's no change or the behavior gets worse, the process recycles with new efforts to clarify the patient behavior or the appropriate nursing action. Again, this deals a lot with the nursing care plans, how they're not standard or they're not set. You do have to look at your patient and do your assessments and modify and alter that care plan as progression or regression develops while the patient is under your care. The nursing process in 5 steps according to Ida Orlando. The assessment, identifying the needs based on the patient's behavior. Diagnosis, identify what is needed for that help. Again, it's not just set in stone, and you're not just going to have one diagnosis that you're going to have to need with these patients. Some come with multiple complaints. Plus, you also have to anticipate, if you do one nursing action, what the impact is going to be, which could bring to light another diagnosis or alter where you're at now. Planning, goal setting to relieve the patient distress. Again, it's not just a nursing focus. You really can't do that without interacting with the patient and having the patient's input based on that plan. So you both have something to strive for, and the patient feels empowered and kind of owns that responsibility to try to meet that plan. Implementation, carrying out the plan goals. Again, it's not just an individual effort. It has to be a joint planning. And evaluation, determine if the need is met and how effective was it with your planning. Again, it's a fluid document, so it's going to go back and forth through all 5 of these steps. The intent of Ms. Orlando's theory, since the nurse and patient are both people, they interact and a process goes on between them. A sequential relationship that can be identified according to Orlando. Contention, that is the inability of the persons to meet their own needs or carry out prescribed medical measures, must precede the requirement for nursing. So again, it's kind of self-explanatory, where the patient cannot meet the needs medically and is seeking help from the nurse, either through the emergency room setting, through the physician setting, through primary care, any action that's going to include the patient and the nurse together. And she imposes 3 science disciplines for her theory: sociology, psychology, and medicine. The effects of this theory on practice. And the survey that I found was nurse leaders initiate the theories in their department. It gives nurses a tool to satisfy patients and themselves. Again, nursing is not just one-dimensional. It does require the patient's input, and a strong nurse that's going to follow theory and evidence-based practice will bring the patient into that and then incorporate the patient's input. But we have to remember that we can't talk above our patients either. We have to include them. And sometimes we do have to break it down to simpler terms, but we need to work on a common plan. And again, nurses feel more rewarded when they can rediscover their unique contribution to patient care, whether that be through teaching, whether that be just through hands-on, or just being at the bedside and teaching, making the patient feel like a patient as a human being instead of just a product of our medicine system and what we need to do. And they develop a doing more with less attitude, being you have the knowledge, you have the resources, you just have to do them. And yes, a lot of it doesn't require a lot of medical intervention as far as like IVs or dressing changes. Yes, they're involved, but they're not the main goal of what we need to do. We need to make sure that the patient does understand on a self-worth sense more than anything else on what we need to do as far as nurses. The impact on nursing, Orlando's theory emphasizes on what nurse-client interactions and considers nurse perceptions, thoughts, and feelings. It views clients as a participant in caregiving, so teaching this theory can enhance student communication skills and improve quality of nursing care. Again, it's not, you can't teach communication skills. You can't, well, you can, I guess, in a broad sense, teach communication skills, but it's something that's also has to be within the nurse themselves. We chose this profession because either we like to help, either we like to see results where patients are healthier and individuals are healthier. And it just kind of gives you that tool to do that, and that understanding that we are both humans and we both have needs and wants, and it does go back and forth. But as far as the self-satisfaction goal, we need to find a happy medium and somewhere where the nurse can get joy and that feeling of worth from what we do as far as with our patients. The theory enhancements improve problem-solving ability and need for developing some skills like critical thinking, critical decision-making. And again, the big part there, making proper diagnoses or problems. Again, it's a fluid document. So when you do one interaction, you have to kind of anticipate something else going on where you might have to take 2 steps backwards and talk with the patient to make sure they thoroughly understand what needs to happen next. And again, they're recognizing patterns in client responses and understanding their feelings and anxieties. So if you can start kind of planning ahead with that, you can kind of get a better idea of what you need to do and how to teach that aspect to reduce those anxieties in the patients that we deal with. Nursing responsibilities. In a survey I found that's listed, it was actually done on an Iranian paper that was done with distressed clients. And it was found in the Iranian Journal of Nursing and Midwifery Research. And with that reports, you can see 25% of the nurses explain their thoughts instead of feelings. I think we sometimes want to express our thoughts on certain things instead of how we really feel. Either it's with our coworkers or with the patients. Yes, I can understand how sometimes if you express your feelings to patients, they get this feeling of untrust or that you're not competent. But I think in the long term, it actually brings light that the patient can actually relate to you, where you're more of an equal and you're partners instead of the domineering, I'm the nurse, do as I say, and this is how it's going to be. The biggest one I found was 50% of the head nurses manipulated the problematic situation by themselves. 50% of cases that they dictated their actions to the nurses. It's not going to allow the nurse to broaden out the care plans and to take on the responsibility with the patients, with the head nurse kind of overbearing. I think the key term here, I think, would be micromanagement. There's other ways to manage, and there's other ways to allow this kind of behavior between the nurse and the patient without conflicting the main vision of the hospital or the floor, just to keep the patients enrolled in their health care. The immediate nurse and head nurse responses were automatic. Again, we're dealing with people. People have feelings, emotions and stress levels, fluctuate throughout any given interaction you have with your patients. You can't have these cookie cutter responses to things that happen. The patients can see right through that. And I feel as a nurse, I've been practicing for 18 years, and every day I go to work, I always try to find something new to do. I love the research and the evidence-based practice. And it all seems to come back to the basics, which is what we were taught in school, that, we're human, the patients are human, they need our help. And you kind of sometimes have to do a little role reversal on what you would like to hear somebody say if something was if you were distressed or if you were under pressure. What would you like another nurse to say to you to help you get through that? Because sometimes I think we forget and just kind of overbearing with our patients. Increasing distress and decreasing quality of nursing care was the result of that study. And with those numbers, it doesn't take much to throw things off. And I think we do need to monitor ourselves, but we also need to make sure that we keep the patient fully engaged in what we need to do as far as nurses. And the reference pages I found for my research. Well, I hope this theory or the PowerPoint presentation does help with the identifying Ida Orlando's nursing theory. Thank you very much.